Okay, let's unpack this. Welcome back to the deep dive.
Yeah.
Today, we are digging into a symptom that sounds pretty simple on the surface, abdominal swelling, but, well, as our sources show, it can really open up a whole universe of medical understanding.
Absolutely.
We got a stack of material here, really focusing in on this area, guiding us through what looks like chapter 50 of a key medical text.
It's quite a dense chapter.
It really is. And our mission in this deep dive, is to go beyond just naming the symptom. We want to navigate all the layers of complexity that are presented in this source material.
Right.
Understanding the potential causes of this swelling, how professionals actually approach diagnosing it, getting to grips with the often really intricate why behind fluid buildup like ascites, and exploring how these conditions are managed and, the potential issues that can crop up. Think of this as getting a shortcut to truly understanding the landscape of abdominal swelling, seeing it through the detailed lens our source provides.
That's a great way to put it. The material we have for this deep dive is exceptionally thorough. Abdominal swelling is one of those clinical presentations that just demands a systematic approach precisely because, like you said, it can be a red flag for such a diverse range of diseases.
Yeah.
The structure of this chapter offers a fantastic guide, moving from the basic presentation right through to the most complex pathophysiological mechanisms. Understanding these topics deeply, as laid out here, is absolutely fundamental to grasping the clinical realities involved.
So let's jump right in then, starting with the fundamental question the source poses. What is abdominal swelling from the patient's perspective? How do they actually experience and describe this?
Well, the source starts by telling us that patients typically report feeling things like bloating or maybe just a sense of abdominal fullness. But what really catches their attention and often brings them in for evaluation is a noticeable increase in their abdominal girth.
Right, the size itself.
Exactly. They'll tell you, my clothes feel tight or my belt size has gone up. That objective increase in physical size is a key part of the picture here.
And the source makes an interesting point about the type of discomfort reported, specifically distinguishing between general discomfort and actual pain.
Yes, and that distinction is crucial, as the source highlights. While discomfort is very commonly associated with the swelling, significant abdominal pain is actually less frequent.
Okay.
So when pain is present alongside the swelling, the text points out that it raises suspicion for something more acutely serious. We're talking possibilities like an intra-abdominal infection, inflammation of the abdominal lining that's peritonitis, or maybe pancreatitis. That presence or absence of significant pain immediately starts to narrow down the diagnostic possibilities.
I was surprised to see the source mention symptoms like new hernias or even difficulty breathing as related to abdominal swelling. How does it connect those?
Well, it's really about the mechanics of the distension itself. When the abdomen fills up, especially with fluid like ascites, it creates increased internal pressure.
Okay.
The source explains this pressure can push outwards on, weak spots in the abdominal wall, leading to the development of new inguinal or umbilical hernias.
Makes sense.
And for difficulty breathing dyspnea, that distended abdomen pushes upwards against the diaphragm, the muscle below the lungs that's crucial for breathing.
Right.
This upward pressure restricts the diaphragm's ability to move down fully, which then limits lung expansion and makes it harder to take a deep breath. It's really a direct mechanical consequence of all that swelling.
Okay. That gives us a much clearer picture of the symptom itself and its immediate effects.
Yeah.
Now, how do we even begin to categorize the vast array of potential causes? Our source gives us a really helpful framework, the 6Fs.
Yeah, this mnemonic is invaluable for organizing our thinking, according to the source. It provides 6 broad categories for the causes of abdominal swelling: flatus, fat, fluid, fetus, feces, or a fatal growth.
Fatal growth.
Yeah.
That sounds a bit dramatic.
It is a bit dramatic, isn't it? But it effectively captures the idea of an abdominal mass, often a neoplasm or tumor. It gets the point across.
Okay, let's break down each one then, starting with the first F, flatus, or intestinal gas. The source even gives us some interesting details about the normal amount and makeup of this gas.
It does. The source notes that the normal small intestine typically contains around 200 milliliters of gas. And this gas isn't just one thing, it's a mix. You have nitrogen and oxygen, which largely come from air that we swallow, a process called aerophagia.
Aerophagia, right, swallowing air.
Exactly. The other components, carbon dioxide, hydrogen, and methane, are produced internally, primarily by bacterial fermentation happening right there in the intestine.
So some of the gas is simply swallowed air. How does the source describe scenarios where someone might swallow too much air?
Well, the text lists several common culprits for increased aerophagia. Things as simple as gulping down food or drinks too quickly, chewing gum, smoking, and interestingly, anxiety.
Anxiety.
Yes, anxiety can lead to repetitive swallowing and belching as almost a nervous habit.
Huh. Okay. And the other gases are produced by gut bacteria, you said?
Exactly. That's the fermentation piece. This happens when undigested substances reach the bacteria down in the colon. The source specifically mentions excess fermentable materials like lactose.
Like in dairy for people who are intolerant.
Precisely. And other types of oligosaccharides found in various foods, beans, certain vegetables. The bacteria metabolize these, producing hydrogen, carbon dioxide, or methane gas, which can lead to significant distension and discomfort for the person.
The source notes that sometimes, even with this understanding of gas, the feeling of distension can be complex, especially in conditions like irritable bowel syndrome or IBS.
That's a really important nuance brought up in the text. For people with IBS who complain of bloating, the subjective sense of distension might not always correlate with an increased volume of gas.
So it's not just more gas.
Not necessarily. Instead, the source suggests it could be due to an impaired ability of the intestines to properly transit or move the normal amount of gas through the system. It just gets stuck. Or maybe the perception of it is amplified.
Oh, okay.
For managing this in IBS, the source points to therapies aimed at gut function and perception, such as abdominal wall relaxation techniques, modifying the diet to reduce those fermentable substances we talked about.
The FODME diet, maybe?
That kind of approach, yes. Also, attempting to manipulate the intestinal microbiota and even biofeedback techniques. And the source also includes a less common but purely physical reason for apparent distension, an exaggerated curve in the lower back known as increased lumbar lordosis.
Just posture, basically.
Essentially, yes. This postural change can make the abdomen simply appear to protrude more, even without any actual internal swelling.
All right, let's move to the second F fat. This seems pretty straightforward. Put on weight, get a bigger belly. But the source connects it to specific health conditions and risks.
That's right. Increased abdominal girth due to fat accumulation is definitely a common cause, stemming primarily from weight gain driven by a caloric imbalance, taking in more energy than you burn, often due to, well, diet and lack of physical activity.
Usual suspects.
Exactly. The source also mentions it can be a feature of specific endocrine disorders like Cushing's syndrome, which affects hormone balance.
Okay.
And this is a key insight from the source. Beyond just the physical appearance, excess abdominal fat is significantly linked to increased health risks. It's strongly associated with the development of insulin resistance and cardiovascular disease.
Right, the metabolic implications.
Precisely. So this type of abdominal swelling carries important metabolic implications that go far beyond just, needing a bigger belt size.
The third F fluid. The source specifically highlights ascites here.
Yes. Within this 6Fs framework, fluid is primarily referring to ascites, which is the accumulation of abnormal amounts of fluid within the peritoneal cavity, that space inside the abdomen surrounding the organs.
Okay.
The source points out this is a major cause of abdominal distension and explicitly states they will delve into the mechanisms and management of ascites in significant detail later, which is exactly what we plan to do.
Good, because that seems like a big one.
It is. And the source also provides a handy grading system for how noticeable ascites is. Grade 1 is minimal, really only detectable by imaging like ultrasound.
Okay.
Grade 2 is moderate, you'd notice it on physical examination. And grade 3 is marked, causing obvious tense abdominal distension.
Fourth F, fetus. This one's pretty intuitive pregnancy. The source gives us a time frame.
Yeah, this one's clear. The source notes that the increase in abdominal girth due to pregnancy typically becomes noticeable when the growing uterus moves out of the pelvis and into the abdominal cavity, usually around 12 to 14 weeks of gestation.
So end of the first trimester, roughly.
Right. However, the text adds that some perceived distension might occur even earlier than this time frame, potentially influenced by hormonal changes causing fluid retention or maybe relaxation of the abdominal muscles.
Fifth F, feces.
Yeah.
What does the source describe as the mechanism here?
This category refers to a buildup of stool in the colon. The source explains that in cases of severe constipation or, more drastically, intestinal obstruction, the sheer volume of impacted stool can cause the abdomen to swell and increase in girth.
Just sheer volume.
Pretty much. This cause is usually accompanied by classic symptoms like abdominal discomfort or pain, nausea, and vomiting. The diagnosis in these cases is often confirmed by imaging studies that can visualize the large amount of stool or the actual point of obstruction.
And finally, the sixth F, fetal growth. That ominous sounding one again.
Right. It is a bit of a catch-all. The source uses this term to cover any abnormal mass growing within the abdomen that's large enough to cause noticeable swelling. This includes things like neoplasms tumors, whether benign or malignant abscesses, which are collections of pus from infection, or large cysts, which are fluid-filled sacs.
So not just cancer then.
No, not exclusively, although that's often a primary concern. Under the same category, the source includes significant enlargement of normal intra-abdominal organs, specifically mentioning hepatomegaly, an enlarged liver, and splenomegaly, an enlarged spleen.
Right.
A dangerous dilation of the abdominal aorta, an abdominal aortic aneurysm, can also sometimes present as a pulsatile mass causing distension if it gets quite large. And the source reminds us that even a severely distended urinary bladder, maybe from inability to urinate, can cause lower abdominal swelling.
So the 6 Fs give us our initial list of suspects, a really good starting point. But once someone presents with swelling, how does the source guide us through the process of figuring out which F is the problem? It really seems to emphasize starting with a thorough history and physical exam.
Absolutely. The source stresses that the detective work begins with gathering information. Taking a good history involves asking specific questions to uncover clues pointing towards one of the Fs. For example, you'd look for symptoms suggestive of a malignancy, like unexplained weight loss, drenching night sweats, or loss of appetite anorexia.
Those red flag symptoms.
Exactly. You'd also ask about the timing and nature of bowel movements, looking for symptoms of severe constipation, ileus, where the gut just stops moving, or outright bowel obstruction. Things like inability to pass stool or gas, often combined with nausea and vomiting.
Okay.
Questions about excessive belching or eructation or increased gas passage, flatus, could point back towards eryphagia or those fermentation issues we discussed.
Connecting back to the flatus F.
Precisely. And it's vital to ask about risk factors for chronic liver disease, like a history of significant alcohol use or symptoms like jaundice, that yellowing of the skin and eyes, as these are strong indicators that ascites might be the cause.
Right.
And the source reminds us to inquire about symptoms of other medical conditions that can lead to ascites, such as symptoms of heart failure or maybe a history of tuberculosis.
The physical examination seems equally critical, looking for clues not just in the belly but throughout the body.
It is. The source outlines a systematic physical exam. First, you're looking for signs of underlying systemic disease. Swollen lymph nodes, particularly above the left collarbone, known as Virchow's node, that's a concerning finding that can signal metastatic cancer in the abdomen.
Wow, a neck lump suggesting abdominal cancer.
It's a classic sign, yes. A careful cardiac exam is also essential because heart failure can cause fluid backup. You'd look for signs of fluid overload and pressure backing up, like elevated pressure in the neck veins, the jugular venous pressure, or JVP. Also things like Kussmaul's sign, where that neck pressure actually increases with inhalation instead of decreasing. Or listening for sounds like a pericardial knock or a heart murmur, suggesting issues like tricuspid regurgitation. All signs the heart might not be pumping effectively, causing fluid to pool.
And specific signs of liver disease.
Yes, given that liver disease is such a huge cause, you specifically look for signs of that on the skin and elsewhere. Spider angiomas, those tiny red spider-like blood vessels, often on the upper body.
I've seen pictures of those.
Yeah. Palmar erythema, reddened palms. Prominent dilated veins around the navel forming a caput medusae.
Like on Mrs. Head, right?
Exactly. And in men, gynecomastia, which is breast tissue development. These all point strongly towards chronic liver problems.
Then, of course, the direct examination of the abdomen itself. What does the source detail there?
The source details this thoroughly. You start with inspection, simply observing the abdomen. Is the swelling symmetrical or uneven? Is there an obvious visible mass or bulge?
Just looking first?
Just looking. Next is auscultation, listening with your stethoscope. The absence of any bowel sounds at all, or instead hearing high-pitched sort of tinkling sounds localized in one area, can point towards ileus, the gut isn't moving, or a mechanical obstruction.
Okay.
The source also mentions some rare findings like an umbilical venous hum, which suggests high pressure in the portal vein system going to the liver, or a harsh bruit, a turbulent blood flow sound heard over the liver itself, which could indicate liver cancer or severe alcohol-related liver inflammation.
Then percussion, tapping.
Yes, percussion. Tapping on the abdomen is key for differentiating gas from fluid or a mass. The source explains that an abdomen distended primarily by gas will sound tympanic, like hitting a drum.
All right.
An area overlying a mass or filled with fluid, like ascites, will sound dull. Now here's a crucial practical detail from the source. Detecting dullness on physical exam actually requires a significant amount of fluid, a minimum of about 1,500 milliliter of acidic fluid.
1.5 liters? Wow.
Yeah, quite a bit. So the absence of dullness on physical exam doesn't necessarily mean there's no ascites. There might just be less than 1.5 liters, which would still require imaging to detect reliably.
Good point. And finally, palpation. Feeling the abdomen.
Right, palpation. This is where you can assess for tenderness. Is there pain when you press? Can you feel a distinct mass? Are the spleen or liver enlarged, splenomegaly, hepatomegaly?
You can feel those.
Often, yes, if they're significantly enlarged. And if the liver is enlarged, what's its texture like? Is it smooth or nodular, bumpy, which might suggest cirrhosis or tumors? The source even notes that in severe right-sided heart failure with tricuspid regurgitation, you might actually feel pulsations transmitted from the heart into the enlarged liver during light palpation.
That systematic approach combines physical clues with potential underlying conditions. Beyond the hands-on exam, the source discusses imaging and laboratory tests to really refine the diagnosis. What are the standout tests mentioned there?
The source highlights several imaging modalities and their utility. Simple abdominal x-rays can show dilated loops of bowel, helping confirm intestinal obstruction or ileus. Useful, but basic.
Okay.
Abdominal ultrasonography is presented as highly sensitive for detecting ascites. The source says it can pick up as little as 100 milliliters of fluid.
Much less than the physical exam needs.
Much less, yes. Ultrasound is also good for visualizing the size and texture of the liver and spleen and detecting masses within the abdomen. However, the source cautions that ultrasound often isn't great for seeing things hidden behind bowel gas, like lymph nodes in the back of the abdomen, retroperitoneal lymphadenopathy, or issues with the pancreas.
Gas gets in the way.
So CT scan for those. Yes, CT scans are recommended when there's suspicion for malignancy or pancreatic disease, as CT is less bothered by gas. The source notes CT can clearly show the changes of advanced cirrhosis and portal hypertension, describing how figures in the chapter illustrate a cirrhotic nodular liver. It's also excellent at detecting peritoneal carcinomatosis cancer spread on the abdominal lining, again noting illustrations in the source showing this with accompanying ascites.
And the lab tests, what's crucial there?
On the lab front, the source emphasizes a suite of tests. Liver biochemical tests, serum albumin, and prothrombin time, measured as INR, are essential to assess how well the liver is actually functioning.
The liver function tests, LFTs.
Commonly called that, yes. A complete blood count, CBC, is needed to look for low blood cell counts, cytopenias, which can occur with portal hypertension, or signs of infection or inflammation like a high white cell count, leukocytosis, anemia, or a high platelet count, thrombocytosis. Serum amylase and lipase are the key tests if acute pancreatitis is suspected. Urinary protein quantitation is indicated if nephrotic syndrome, a kidney issue causing protein loss and sometimes ascites, is on the differential diagnosis list.
Right.
And the source mentions breath tests that detect hydrogen and methane gases. These are the basis for diagnosing small intestinal bacterial overgrowth, SIBO, which, as we discussed, can cause excess gas and bloating.
Flying back to the flatus F again.
Exactly. Finally, the source notes that in specific challenging cases, more invasive procedures might be required. Measuring the pressure gradient across the liver veins via hepatic vein cannulation can confirm if ascites is being driven by high liver pressures, like in cirrhosis. And sometimes a liver biopsy is ultimately necessary to definitively diagnose cirrhosis itself.
Okay, so we've touched on fluid being one of the 6 Fs. Now, as the source promised, let's really dive deep into ascites itself, which it states is the most common cause of significant abdominal swelling.
That's right. The source is very clear. Cirrhosis is the single most frequent cause, accounting for a significant 84% of all ascites cases. So, really, understanding ascites means understanding its connection to liver disease, primarily cirrhosis.
And the source provides a detailed multi-step explanation of how ascites forms in the presence of cirrhosis. It seems quite a complex pathway. Let's walk through this pathogenesis as the chapter describes it.
It is intricate, but it's fascinating because it involves problems both within the liver itself and also widespread effects throughout the body's blood vessels and the kidneys. It all starts with portal hypertension.
High pressure in the portal vein.
Exactly. Elevated pressure in the system of veins that drain blood from the gut, spleen, and pancreas into the liver. The source explains this pressure increase using a concept borrowed from physics Ohm's law, where pressure is related to resistance and flow.
Pressure equals resistance times flow.
Right. In the liver, portal pressure goes up because there's increased resistance to blood flow through the liver, and often increased blood flow to the liver as well.
So what increases the resistance?
The source details the specific ways resistance increases in cirrhosis. First, the fundamental issue is fibrosis, the scarring that defines cirrhosis. This scarring completely disrupts the normal architecture of the liver's tiny blood vessels, the sinusoids, creating physical barriers to blood flow.
Okay, the scarring itself.
Yes. Second, activated hepatic stellate cells, which are central players in liver fibrosis, also cause the smooth muscle around the sinusoids to contract, effectively squeezing them and increasing resistance even more. They both cause fibrosis and squeeze the vessels.
Double whammy.
Right. Third, the source points out that in cirrhosis, there's a decrease in the production of nitric oxide, NO, within the liver. This happens because the enzyme that makes it, ENOS, is less active. Since NO is a vasodilator, less NO intrahepatically leads to vasoconstriction within the liver, adding yet another layer to the resistance problem.
So scarring, squeezing, and constriction inside the liver.
Precisely. Now, here's the twist. While NO is reduced inside the cirrhotic liver, the source states that cirrhosis is associated with increased levels of vasodilators, including NO, but also others like vascular endothelial growth factor, VEGF, and tumor necrosis factor, TNF, circulating systemically throughout the rest of the body.
Wait, so less NO inside the liver, but more vasodilators outside.
Exactly. It's a paradoxical situation. These systemic vasodilators cause significant widening or vasodilation of the blood vessels in the splanchnic circulation. That's the extensive network of vessels supplying the stomach, intestines, pancreas, and spleen.
Okay, so the gut vessels relax and widen.
Yes. And the consequence of this widespread splanchnic vasodilation, as described in the source, is that a large volume of blood tends to pool in this area.
Pooling in the gut circulation.
Right. This pooling reduces the amount of blood circulating effectively in the rest of the body, particularly the volume reaching the kidneys. The kidneys perceive this as a state of low blood volume or hypovolemia, even if the total amount of fluid in the body is actually normal or even high.
The kidneys get tricked.
Essentially, yes. In response to this perceived hypovolemia, the kidneys launch a powerful compensatory reaction. They release antidiuretic hormone, ADH, which instructs the body to retain free water.
Okay.
More significantly, they activate the sympathetic nervous system and the renin-angiotensin-aldosterone system, the RAAS. Activation of these systems are like master switches telling the kidneys to aggressively retain sodium, and along with it, water.
Sodium and water retention.
Exactly. So pulling it all together as the source presents it, you have increased pressure in the liver trying to push fluid out due to the scarring, the stellate cell contraction, and the liver vasoconstriction, combined with the kidneys working overtime to retain sodium and water because they think the body needs more volume, driven by that systemic vasodilation and pooling in the gut circulation.
So high pressure pushing out and the body holding on to fluid.
Precisely. This confluence of factors causes fluid to leak out of the congested blood vessels, particularly those in the abdomen, and accumulate in the peritoneal cavity, forming ascites. It's a kind of self-perpetuating cycle driven by both the local liver pathology and this misdirected systemic response.
Wow, that is a really deep dive into the mechanics of it. It shows just how complex seemingly simple symptoms can be at a physiological level. So that ascites driven by cirrhosis. What about ascites when cirrhosis isn't the cause? How does the source explain those mechanisms?
Well, the source explains that in the absence of cirrhosis, ascites usually results from issues with the peritoneal lining itself or maybe leakage from nearby structures. The primary mechanisms in this non-cirrhotic category, according to the text, involve the peritoneum becoming inflamed or infiltrated, leading to fluid leakage.
So problems with the lining itself.
Right. The most common non-cirrhotic causes are peritoneal carcinomatosis, peritoneal infection, or leakage from pancreatic disease.
Let's take peritoneal carcinomatosis. First, cancer spread to the lining.
Okay. The source explains this can come from cancers originating in the peritoneum or nearby abdominal organs, like stomach or colon cancer, or even metastases from distant cancers like breast or lung. The mechanism here is that the tumor cells coating the peritoneum actually exude a fluid that is very high in protein.
The tumor cells leak protein-rich fluid.
Exactly. And this protein-rich fluid essentially pulls fluid from the surrounding tissues into the peritoneal space via osmosis due to the protein concentration gradient.
Okay, draws fluid in. What about infection, like TB?
Peritoneal infection, like tuberculous peritonitis, causes ascites through a similar process according to the source. The inflammatory lesions, the tubercles on the peritoneum, also cause a high protein fluid to be exuded, drawing in more fluid, much like with carcinomatosis.
And pancreatic ascites.
As the name suggests, that happens when there's a leak from the pancreas or its ducts, releasing pancreatic enzymes directly into the peritoneal cavity. This can happen in conditions like chronic pancreatitis or maybe after abdominal trauma.
Okay. The source provides a helpful list of the specific causes of ascites, giving us a clear differential diagnosis framework based on how often they occur. Can you run through that?
Sure. It summarizes the landscape nicely. As we've covered, cirrhosis is overwhelmingly the most frequent cause at about 84%.
The vast majority.
Right. The source then groups cardiac ascites, due to heart failure, peritoneal carcinomatosis, and mixed ascites, meaning cirrhosis plus another cause, together as the next most common category, accounting for maybe 10–15% of cases.
Okay.
Then there's a list of less common culprits. Massive spread of cancer to the liver, so hepatic metastases, certain infections beyond TB, though TB is a key one, pancreatitis and renal disease, specifically nephrotic syndrome.
And the rare ones.
And finally, the source lists rare causes such as hypothyroidism and familial Mediterranean fever. Having this list based on prevalence is very practical when you're approaching a patient with new ascites.
Okay, so we have the list of possibilities. Now for the crucial diagnostic step. Once we suspect ascites based on history and physical, how do we confirm it and figure out the cause? The source states that paracentesis is the best initial test.
Paracentesis is presented as the absolute key diagnostic procedure here. The source describes it as a relatively simple bedside procedure where a needle or a thin catheter is inserted through the skin and abdominal wall into the peritoneal cavity to sample the accumulated fluid.
Getting a sample of the fluid.
Exactly. It notes the lower quadrants of the abdomen are commonly used sites, with the left lower quadrant often preferred due to potentially greater fluid depth there, and maybe a thinner abdominal wall, which can make it safer and easier.
Is it safe, though? Especially if someone has liver disease and maybe bleeding issues.
That's a good question. The source emphasizes that paracentesis is generally very safe, even in patients with blood clotting abnormalities or coagulopathy, which are, as you say, common in liver disease. It lists infrequent potential complications like bruising or bleeding in the abdominal wall, hematomas, a drop in blood pressure, hypotension, developing hepatorenal syndrome, which is a severe kidney problem linked to advanced liver disease, or rarely infection of the fluid itself. But generally, it's considered low risk.
Okay. Once we've got the fluid out, what do we look at first? The source describes the importance of its gross appearance.
Right. The visual characteristics of the fluid provide immediate clues, according to the source. If the fluid looks turbid or cloudy, it suggests either an infection or the presence of tumor cells.
Cloudy means infection or cancer cells.
Often, yes. White, milky fluid is the telltale sign of chylous ascites. This indicates a very high level of triglycerides, a type of fat in the fluid, typically above 200 mg/dL and often exceeding 1,000 mg/dL.
Chylous says, what causes that?
The source explains that chylous ascites is usually caused by disruption or blockage of the lymphatic system. It lists potential causes like trauma, cirrhosis itself, tumors, tuberculosis, or certain congenital lymphatic abnormalities. Essentially, lymphatic fluid is leaking into the abdomen.
Okay. What about other colors?
Dark brown fluid suggests a high concentration of bilirubin, which points towards a leak from the biliary tract, the system of ducts carrying bile from the liver and gallbladder.
A bile leak.
Exactly. And black fluid is noted as a possible, though rare, sign of pancreatic necrosis or maybe metastatic melanoma.
After the visual inspection, the fluid goes to the lab for analysis. The source really emphasizes the serum ascites albumin gradient, the SAG, as a primary tool.
The SAG is indeed highlighted as central to the diagnostic workup. The source lists the essential tests to perform on the acidic fluid, measuring the albumin and total protein levels, getting a cell count and differential, specifically noting the PMN or polymorphonuclear neutrophil count is critical, especially for infection.
PMN count, okay.
And if infection is suspected, performing a gram stain and culture. The source gives a vital practical tip here. Inoculating the fluid directly into blood culture bottles right there at the bedside significantly increases the yield of cultures compared to just sending it in a standard sterile container.
Good tip. So how do you calculate the SAG?
To calculate the SAG, you need two measurements taken at roughly the same time: the albumin level in the serum, the blood, and the albumin level in the acidic fluid itself. The calculation is simple. SAG, he's a serum albumin minus acidic fluid albumin.
Serum minus Ascites albumin.
Correct. And the source makes a key point here for clinical practice. The SAG value is stable. It does not change even if the patient is treated with diuretics and loses some fluid volume. It reflects the underlying pressure gradient.
So the SAG is calculated. How does the source instruct us to use this number to figure out the cause? What does a high SAG tell us versus a low SAG?
This is where the SAG acts as the major discriminator, according to the source. A SAG value of 1.1 GDL or higher, that's 001.1 GDL, is highly suggestive of portal hypertension being the underlying driver of the ascites. It signifies that there's significantly elevated pressure within those hepatic sinusoids we talked about.
High SAG means portal hypertension.
Generally, yes. The source explains that this high SAG reflects Starling's law in action, essentially. The hot hydrostatic pressure pushing fluid out from the congested portal system into the abdomen is partially counterbalanced by the oncotic pressure difference created by the higher albumin concentration in the blood compared to the fluid.
Okay.
Causes listed in the source associated with a high SAG, 01.1, are those linked to portal hypertension. Cirrhosis, obviously, cardiac ascites due to pressure backing up from the heart, Budd-Chiari syndrome, which is blockage of the liver veins, obstruction of the inferior vena cava, sinusoidal obstruction syndrome, and also extensive liver metastases.
And a low SAG, below 1.1.
Conversely, a SAG value less than 1.1 GDL, 1.1 GDL, tells you the ascites is not being caused by portal hypertension. The fluid is accumulating through different mechanisms, often related to inflammation or issues with the peritoneum itself, like we discussed.
Like the cancer or infection mechanisms.
Exactly. Causes associated with a low SAG, 1.1, include tuberculous peritonitis, peritoneal carcinomatosis, pancreatic ascites, biliary leaks, and nephrotic syndrome.
The source then seems to refine the diagnosis further for those high SAG cases by looking at the total protein level in the fluid. How does that work?
Exactly. If you have a high SAG, 1.1, indicating portal hypertension, the next piece of information from the fluid analysis is the total protein concentration. The source uses this to differentiate causes within the portal hypertension category.
Okay, so high SAG, now look at protein.
Right. If the acidic protein is relatively high, specifically 2.5 GDL or higher, 2.5 GDL, this suggests the hepatic sinusoids are actually less damaged, allowing more protein to leak through along with the fluid. High SAG, high protein causes listed are cardiac ascites, early Budd-Chiari syndrome, and sinusoidal obstruction syndrome.
So the pipes are leaky but not totally scarred shut yet.
That's a decent analogy. Now, if the acidic protein is low, less than 2.5 GDL, despite a high SAG, this suggests the liver sinusoids are more severely damaged and scarred, like in advanced cirrhosis. This scarring makes them less permeable to protein, so less protein leaks into the acidic fluid even though the pressure is high.
Okay, so less protein gets through the scarred liver.
Correct. High SAG, low protein causes include established cirrhosis, late-stage Budd-Chiari syndrome, and massive liver metastases.
What other specific tests might be needed on the fluid or in the blood, depending on what the SAG and protein are pointing towards?
The source details several specific tests to home in on a diagnosis. If cardiac ascites is suspected, high SAG, high protein, measuring serum levels of probrain-type natriuretic peptide, or BNP, is useful.
BNP for heart failure.
Right. BNP is a hormone released by the heart under strain or volume overload, so high levels strongly support heart failure as the cause.
Okay. What if you suspect secondary peritonitis, like a bowel perforation?
Good question. If you suspect secondary peritonitis and infection originating from maybe a hole in the gut or an abdominal abscess, the source notes, you'd look at acidic glucose and lactate dehydrogenase, LDH levels. Secondary peritonitis typically shows a low acidic glucose, less than 50 mg/dL, an acidic LDH level higher than the simultaneous serum LDH level, and crucially, cultures showing multiple different types of bacteria.
Multiple bacteria, not just one like an SBP.
Exactly. This contrasts sharply with the single organism usually found in spontaneous bacterial peritonitis, or SBP, which we'll discuss as a complication shortly. The source also adds a note that finding multiple organisms without an elevated PMN count might just mean the paracentesis needle accidentally nicked the bowel during the procedure.
Okay. What about pancreatic ascites?
For suspected pancreatic ascites, the key test is the acidic amylase level. The source says this is typically very high, usually above 1,000 mg/dL.
Okay. And for cancer.
Cytology, where a pathologist examines the fluid from malignant cells, is vital for diagnosing peritoneal carcinomatosis. The source recommends sending at least 50 milliliters of fluid for this and ensuring it gets processed quickly for the best results.
And TB. You mentioned it was tricky.
Diagnosing tuberculous peritonitis can be tricky by fluid analysis alone. While the fluid typically has a high lymphocyte count, the source notes that finding the bacteria via smear, acid-fast bacilli, AFB, is rarely successful, like 0.3% sensitivity.
Almost never find it on smear.
Right. And even cultures are only positive in maybe 35–50% of cases. However, the source highlights that an elevated acidic adenosine deaminase, ADA level, is quite sensitive, over 90%, with a cutoff between 30 and 45 UL for TB peritonitis, particularly in patients who do not have cirrhosis. ADA can be elevated in cirrhosis too, so it's less specific there.
Okay, ADA is helpful, especially if no cirrhosis. What if you're still unsure after all this?
Finally, the source states that in challenging cases where the cause of ascites isn't clear, especially in non-cirrhotic patients, the gold standard for definitive diagnosis is often a surgical procedure, laparotomy or laparoscopy, to directly visualize the abdominal lining and take biopsies for microscopic examination and culture.
Going in to look directly.
Sometimes that's what it takes.
Okay, so we've identified the cause using this pathway. Now, how does this chapter guide us in terms of treating the ascites? Let's start with cirrhotic ascites, given it's so common.
Right. For cirrhotic ascites, the initial and foundational treatment step, according to the source, is dietary. Restricting sodium intake to no more than 2 grams per day. Reducing the salt you take in directly reduces the body's drive to hold on to water. It's step 1.
2 grams. That's pretty strict.
It is. It requires careful attention to food labels and avoiding processed foods. If sodium restriction isn't sufficient by itself to control the fluid buildup, the source indicates that oral diuretics are added.
Water pills.
Exactly. The standard regimen involves the combination of 2 medications, spironolactone and furosemide. The aim is simply to increase the excretion of sodium in the urine, and water follows the sodium, thereby removing excess fluid from the body.
How do they work differently? Spironolactone first.
The source explains spironolactone's role. It's an aldosterone antagonist. Aldosterone is that hormone in the RAAS system we talked about in pathogenesis that tells the kidneys to hold on to sodium. Spironolactone blocks this action in the distal part of the kidney tubules.
Okay, blocks sodium saving.
Right. The source notes that spironolactone can have side effects like hyponatremia, low blood sodium, hyperkalemia, high blood potassium, and in men, often painful gynecomastia or breast enlargement.
And furosemide.
Furosemide is a loop diuretic. It works on a different segment of the kidney tubules, the loop of Henle, also promoting sodium and water excretion. The source mentions a common strategy is to use these 2 diuretics in a specific ratio, often starting at 40 milligrams of furosemide for every 100 milligrams of spironolactone.
40 to 100 ratio.
To help maintain potassium balance, because furosemide tends to waste potassium while spironolactone spares it. But the doses are titrated based on the individual's response and weight loss. The source gives the maximal recommended daily doses: 400 milligrams for spironolactone and 160 milligrams for furosemide.
And fluid intake.
It also adds that in patients who develop hyponatremia, low sodium, their fluid intake might need to be restricted in addition to the sodium restriction.
What happens if the ascites just won't go away despite the diet and these maximal diuretic doses? The source defines this situation as refractory ascites, right?
That's right. Refractory cirrhotic ascites is specifically defined in the source as ascites that persists despite adherence to the low-sodium diet and treatment with maximal or maximally tolerated doses of diuretics. It's a really challenging clinical problem.
So what can be done then? Are there other medications?
For refractory ascites, the source discusses adding specific medications to the diuretic regimen, such as midodrine, which is an alpha-1 adrenergic agonist, or clonidine, an alpha-2 adrenergic agonist.
How do those help?
The idea behind these, the source explains, is that they act as vasoconstrictors. They help to counteract that splanchnic vasodilation, the widening of gut blood vessels that contributes to the fluid pooling and kidney issues in cirrhosis.
Addressing the systemic vasodilation part of the problem.
Exactly. The source mentions findings suggesting that adding midodrine, sometimes with clonidine, can improve blood flow hemodynamics and control ascites better than just diuretics alone in these refractory patients.
Interesting. Any warnings with these meds?
Well, not specifically with those, but here's a crucial warning from the source related to other common cirrhosis meds: beta blockers. While beta blockers are widely used in patients with cirrhosis to prevent bleeding from varices,
Right, for esophageal varices.
yes, their use in patients who have refractory ascites may be associated with decreased survival rates. This is a complex and debated area, but the source highlights this potential risk, suggesting caution with beta blockers once ascites becomes refractory.
That's a really important clinical point. So if medications still aren't enough for refractory ascites, the source describes interventional procedures. What are the options?
Yes, for patients with truly refractory ascites, there are procedural options. One is repeated large volume paracentesis, or LVP. This simply means serially draining large amounts of fluid, often several liters at a time, whenever it reaccumulates enough to cause symptoms.
Just keep draining it.
Essentially, yes. But the source strongly emphasizes that when performing LVP, it's crucial to administer intravenous albumin alongside it.
Why the albumin?
The source notes that giving albumin significantly decreases the risk of something called post-paracentesis circulatory dysfunction. This is a serious complication where the blood pressure and circulation can worsen dramatically after removing large fluid volumes. Albumin infusion helps maintain circulatory volume and function, and the source states it also reduces the risk of death.
Okay. How much albumin?
The recommended dose given in the source is 6 to 8 grams of albumin for every liter of acidic fluid removed.
Got it. What's the other main procedure? TPS.
Yes, the other major interventional option is the transjugular intrahepatic portosystemic shunt, or TPS. This is a shunt placed by an interventional radiologist, usually going through a neck vein, down into the liver. It creates a direct channel connecting the high-pressure portal vein to a lower-pressure hepatic vein.
So it bypasses the resistant liver tissue.
Exactly. It decompresses the high pressure in the portal system. The source compares TPS to repeated LVP and states that TPS is superior in preventing ascites from coming back. Patients need fewer drainage procedures.
Sounds better then.
Well, there's a significant trade-off mentioned. TPS is associated with a higher frequency of hepatic encephalopathy, that's brain dysfunction due to liver failure, because toxins bypass the liver filtering. And crucially, the source notes that despite better ascites control, studies show no difference in overall mortality rates between TPS and repeated LVP.
So better fluid control, but more brain fog, and doesn't help you live longer overall.
That's the gist of it, according to this source. It's a complex decision based on patient factors and quality of life goals. The source also briefly mentions the alpha pump system as a potentially promising newer technology for refractory ascites management.
What's that?
This system uses an automated pump and a tunneled catheter to actively move fluid from the abdominal cavity to the bladder so the patient just urinates it out. However, the source notes that this system has been associated with a higher frequency of technical issues and problems with kidney function, so it's still evolving.
Okay. What about treating malignant ascites? Does that respond to the same treatments as ascites from cirrhosis, like diuretics?
No, the source is very clear on this. Ascites caused by malignancy does not typically respond to sodium restriction or standard diuretic therapy like cirrhotic ascites does.
So diuretics don't work for cancer-related ascites.
Generally not. The management for malignant ascites listed in the source primarily focuses on drainage. This includes repeated large-volume paracentesis, sometimes placing a semi-permanent transcutaneous drainage catheter to allow for ongoing drainage at home, less commonly using a peritoneovenous shunt, which shunts fluid to the bloodstream, or potentially using that alpha pump system if it's available and appropriate.
And for ascites from other causes, like infection or pancreatitis.
The general principle the source provides for ascites not caused by cirrhosis is that the management focuses on treating the underlying precipitating condition. For example, ascites caused by tuberculous peritonitis is treated with standard anti-tuberculosis medication regimens. Once the underlying problem, like the TB infection, is addressed, the ascites should resolve. Same idea for pancreatitis or other causes.
Treat the root cause. Makes sense. Now, ascites itself isn't just uncomfortable, it can lead to further problems. What significant complications does the source highlight?
The most critical complication discussed is spontaneous bacterial peritonitis, or SBP. The source labels it as a common and potentially life-threatening complication seen most frequently in patients with cirrhotic ascites.
Spontaneous infection of the fluid.
Exactly. While less common, the source notes it can also occur in ascites from other causes like nephrotic syndrome, heart failure, or acute liver failure, but it is specifically noted as being rare in malignant ascites.
What signs should we look for that might suggest SBP, according to the source? How does it present?
The source highlights that the presentation of SBP can actually be quite subtle. Patients generally report an increase in their abdominal girth, maybe some new or worsening discomfort. However, classic signs like significant abdominal tenderness are only present in about 40% of patients. And rebound tenderness, that sharp pain when pressure is quickly released, is uncommon.
So it might not be obvious abdominal pain?
Right. Other possible symptoms listed include fever, nausea, vomiting, and importantly, new onset or worsening of hepatic encephalopathy confusion or altered mental state. The potential lack of dramatic abdominal signs means you have to maintain a high index of suspicion and consider SBP in any patient with ascites who has any change in their condition.
Given that subtle presentation, how is SBP diagnosed, especially in hospitalized patients?
This source emphasizes that the absolute crucial diagnostic step is performing a paracentesis to obtain that fluid for analysis. Get the fluid.
Tap the belly.
Yes. The source cites evidence showing that performing paracentesis within 12 hours of hospitalization for a patient with ascites actually reduces mortality, highlighting the importance of early detection of SBP. Don't wait.
Okay. And what in the fluid tells you it's SBP?
The definitive diagnostic criterion for SBP, as provided by the source, is that polymorphonuclear neutrophil count, the PMN count in the acidic fluid. If it's 250 cells per microliter or higher, O250 Le, that signifies infection. That's the number.
PMN count 250. Got it. What about the cultures?
Regarding cultures, the source reiterates the importance of inoculating the fluid into blood culture bottles right at the bedside for best yield. In SBP, these cultures typically grow just one type of bacteria.
Usually just one bug.
Usually. And this helps distinguish SBP from that secondary peritonitis we mentioned earlier, the one from a bowel perforation or abscess. The source clarifies that finding multiple different bacterial types in the culture, along with an elevated acidic PMN count, strongly suggests secondary peritonitis.
Multiple bugs plus high PMNs means a hole somewhere.
That's the implication. The source also adds that finding multiple organisms without an elevated PMN count might just mean the bacteria were introduced during the paracentesis procedure itself, maybe by accidentally passing the needle through the bowel, a procedural contamination.
Okay. Where do the bacteria in SBP usually come from?
The source briefly touches on the pathogenesis, explaining it commonly results from bacteria that normally live in the gut enteric bacteria crossing the wall of an edematous, swollen, and leaky bowel into the normally sterile acidic fluid. It's called bacterial translocation.
Bacteria leaking across the gut wall.
Yes. The most frequent types of bacteria listed are gram-negative rods like E. coli and Klebsiella, as well as gram-positive cocci like Streptococci and Enterococci, common gut bugs.
How is SBP treated once it's diagnosed?
Treatment involves antibiotics, given intravenously. The source states that IV cifotaxime, a third-generation cephalosporin, is generally effective against the common aerobic bacteria causing community-acquired SBP.
Okay, cefotaxime usually works.
Usually. However, it adds a vital point for healthcare-acquired SBP, infections picked up in the hospital. These are increasingly caused by multi-drug-resistant bacteria. In those situations, the source stresses that the initial choice of antibiotics must be guided by what's known about the local patterns of bacterial resistance in that specific hospital or region. You need broader coverage initially.
Tailored to local resistance patterns. Can SBP be prevented in high-risk patients?
Yes, the source discusses prophylaxis or prevention. It is recommended for cirrhotic patients who are at particularly high risk of developing SBP. This includes patients who have previously had an episode of SBP.
Makes sense.
Those with a low total protein concentration in their acidic fluid, less than 1 GDL, because lower protein means fewer natural infection-fighting substances called opsonins in the fluid, or those experiencing active gastrointestinal bleeding, like from varices, which increases the risk of bacteria crossing the gut wall.
So, previous SBP, low protein fluid, or GI bleed. What antibiotics are used for prevention?
The source lists the prophylactic agents used. Typically oral daily ciprofloxacin, or where available norfloxacin, both are fluoroquinolones. For patients in the hospital who need prophylaxis, 5-E ceftriaxone may be used.
Daily pills usually.
Right. The source also makes an interesting note that successful diuresis, effectively treating the ascites and reducing the fluid volume, seems to increase the activity of those protective opsonins in the remaining fluid, and may therefore also reduce the risk of SBP. So treating the ascites itself helps prevent infection.
Good point. Finally, the source mentions hepatic hydrothorax as another complication. What is that exactly?
Hepatic hydrothorax is a complication where ascites fluid, most commonly from cirrhosis, accumulates in the pleural space, that's the area between the lung and the chest wall. Fluid in the chest cavity.
How does it get there from the abdomen?
The source explains this happens when the fluid migrates upwards from the abdomen through small, usually congenital openings or defects called fenestrae in the diaphragm muscle. It just seeps through these little holes.
Wow. So abdominal fluid ends up around the lungs. What symptoms does that cause?
The symptoms are primarily respiratory, shortness of breath, low oxygen levels in the blood, hypoxia, and also the risk of infection developing in that pleural fluid, similar to SBP in the abdomen.
How is it treated?
The treatment listed is generally similar to that for the underlying cirrhotic ascites: sodium restriction, diuretics, and if needed to relieve the fluid pressure on the lungs, therapeutic thoracentesis, which is draining the fluid from the chest with a needle.
Similar to draining ascites.
Yes. If it's recurrent or severe, TPS placement may also be considered, as lowering the portal pressure can improve both the ascites and the hydrothorax.
Okay. Anything to avoid?
Yes, the source concludes this point with a very important clinical instruction. Chest tube placement should be avoided in hepatic hydrothorax.
Why no chest tubes?
Because these diaphragmatic defects allow continuous fluid passage, placing a chest tube can lead to persistent, massive volume fluid leaks out of the chest tube that are incredibly difficult to manage and can cause serious complications like protein loss, electrolyte problems, and infection. It's generally contraindicated.
Okay. Avoid chest tubes. Got it.
Wow.
We started with a symptom, abdominal swelling, and the source really walked us through a masterclass, didn't it?
It really did.
We've categorized the possibilities with the 6 Fs, learned how a meticulous history, physical exam, and key labs and imaging helped narrow the field, and then took that promised deep dive into ascites, understanding its complex origins from liver failure, the crucial role of paracentesis and the SAG gradient, and the specific treatments and potentially life-threatening complications like SBP and hepatic hydrothorax.
It's truly a comprehensive journey through this one clinical presentation. To follow the source's guidance from the patient's initial complaint all the way through the intricate interplay of portal pressure, vascular changes, renal function, and even immune defense mechanisms, it provides a level of understanding that goes well beyond just the surface.
Yeah.
It really demonstrates the kind of multidisciplinary thinking required in medicine, pulling together physiology, pathology, pharmacology.
It does. It's fascinating to see how concepts from physics like Ohm's law or fluid dynamics principles like Starling's law are directly relevant to understanding why someone's belly might fill with fluid, and how the solutions involve everything from diet and simple pills to complex interventional radiology procedures and targeted antibiotics.
Exactly. It reinforces that clinical expertise isn't isolated. It's about connecting knowledge across different scientific and medical domains to understand the whole picture.
So as you process everything we've covered in this deep dive into abdominal swelling and ascites, reflecting on the detailed pathways and management strategies laid out in our source material.
Consider this provocative thought. Given the central role of those systemic factors we discussed, like the splanchnic vasodilation and the renal sodium retention in driving cirrhotic ascites, might therapies in the future move towards earlier and more aggressive targeting of these specific pathways? Perhaps with novel drugs or interventions aimed right at those mechanisms, rather than primarily focusing on diuretic responses or later-stage procedures like TPS or repeated paracentesis. How might a deeper dive into the earliest drivers of these systemic changes potentially reshape our approach to managing this very common and challenging complication of liver disease? What could that look like?